Welcome to EuroPCR 2019. With me, my two colleagues. Let me first of all introduce myself. I am Dr. Ashwin Mehta, cardiologist at Jaslok Hospital, Mumbai, India. With me is Dr. Upendra Kaul, who is the interventional cardiologist at Batra Hospital, Delhi. And we have with us Dr. Anirban Choudhary, who is from University of Wales, Cardiff. And we will have a discussion amongst three of us. And you know, all these days we were concentrating on the drug polymer, but now I think we should also think about the platform and the importance of platform. And I think starting with Choudhary, who said that the strut thickness is important, and thicker the stent strut, more is the restenosis and also associated with these other side effects. Upendra, you tell me, what is the rationale for using a thin strut stents?
As you rightly said, the concept started way back in 2003 when Dr. Choudhary with his workers showed that the strut thickness of 50 versus 130, restenosis was lower and TLRs were lower. After that came the drug-eluting stents, and this concept got sort of mixed up, and all the energy and concentration was spent on the polymer and the drug. Having leveled that, how to improve the performance of the stents, now we have come to the stage that the platform matters, and thinner the strut, better it is. And in a recent meta-analysis has been seen that strut thickness of 70, which is called the ultra-thin, is clearly superior than thicker stents. And they have lower target vessel failure, mainly driven by reduction in myocardial infarction and reduction in stent thrombosis.
I think, Dr. Choudhary, what do you think? I think there is another issue, and that's a technical issue, the deliverability.
Yes.
Do you have any thoughts about the deliverability? Like, would they conceptually help to deliver them at the target site easily?
Yeah, I mean, you would expect so, because the thicker the struts, bigger the crossing profile. So as you come down on the strut thickness from 140, as Dr. Kaul was saying, to now 60, 65, your crossing profile is substantially reduced. So, and that has made life much easier for me as one of the younger guys. And so I definitely agree that it is the way forward. With deliverability, makes the procedure easier. And obviously there are real life outcome advantages, as we have already mentioned.
But except that one thing that I would anticipate, the two downsides. One is that, would it make any difference in the radial strength? And the second is the visibility. You know, especially when you are dealing with the ostial sites, I think the visibility becomes very, very crucial. And I wonder, and I'm sort of in my own fantasy, in my imagination, whether with the reduction of strut thickness, would we be compromising the radial strength or visibility? Upendra, I mean, what are your thoughts about this aspect?
Well, with the chromium cobalt, because all the ultra-thin stents are chromium cobalt, where the visibility is not a very big issue, number one. Number two, all the data which we are talking about in the meta-analysis by Sripal, Bangalore, which came last year, it is basically not on ostial sites, not on very calcified vessels, and not in CTOs. So
you would not
we don't have the data for that.
You don't have the data.
We need data for that.
I got it.
But in the common garden lesions, which we day to day do, lower strut thickness, and now we have come up to 60 also, leads to less trauma, leads to better laminar flow.
Sure, inflammation also.
Inflammation goes down, and that leads to lower myocardial infarctions, because the branches, side branches, the overlap of the branches by the stent strut is less, so you have less enzyme leaks, and most of the myocardial infarction reduction is because of lower enzyme leaks, and also that leads to lower stent thrombosis. There is no difference in mortality.
But then in that case it leads to another question. I think, Dr. Choudhary, you could say that when we, is there been a robust study or a data? I think concept is comparatively new.
Yeah.
And like that, can we go to 50, 40, 30, 20? There should be some kind of a limit. You can't keep on going in, because there must be some downside, and it should be therefore necessary that at some point we stabilize. And my point is, therefore, is there a data like of late, I think recently we have a talent study which was published in Lancet.
Yes, yes.
Can you throw some light on that study?
The talent study was an RCT, which was in fact probably the first all-comers true in the ultra-thin strut population. The ones before that were more medium risk patients. So this was the first proper all-comers which compared ultra-thin strut Supraflex stent with Xience, which is a thin strut and the market leader. One-to-one design, 1,450 odd patients. And what it showed is it was designed as a non-inferiority, so it met its non-inferiority margins. But if you then look into the absolute numbers, then the ultra-thin strut stent, as has been the suggestion from previous medium risk population, are all in the favor of the ultra-thin strut. And especially what was of note is the ischemia-driven target lesion revascularization TLR was a substantial reduction in the per protocol analysis of nearly 60%.
Right.
And so that has been very welcoming from the interventional community and even increases the data that we already have with regards to evidence emerging in favor of it.
But you didn't answer to my two concerns, the radial strength
Yes.
as well as the visibility. Are they compromised to any extent?
Well, I mean, the reason we went from stainless steel to cobalt chromium were those two factors. So cobalt chromium are more visible than stainless steel. And number two, radial strength, obviously there is a recommendation that it needs to be twice the level of the highest possible blood pressure, so 600 millimeters of mercury. That's the minimum you require for any stent. And all these stents, ultra-thin struts, most of their radial strengths is around 800. And if you compare that with stents like Xience or Promus, they're not too different. So it's just beyond that. The technology, fortunately from the engineering side, is very robust.
I agree with you. I think that we have a radial strength more than what we need.
Yes.
Much
yes.
more than what we need. And then it comes to me that now with the drug-eluting stent with any platform, we had reached the restenosis rate across the board with all kinds of cases taken into consideration to approximately in a single digit, like 6 to 8%. And in fact, in the large size vessel, it came down to almost 2%. And then now with this new platform and a new concept, do you think both safety and efficacy will be still better than what we have been currently using or currently in practice? So in other words, what I'm asking is, what do you think is the future of the metallic stent with the concept of reducing strut thickness?
I think in the smaller vessels, there still is scope.
Yes.
Only yesterday there was a study from the other low ultra-thin stent or zero, where it showed that the long-term results were much better, lower restenosis in vessels less than 2.5. Usually, most studies had taken 2.75 as this thing. So in smaller vessels, I think it, is very logical that if the amount of metal and the thickness is lower, the restenosis will be lower.
That makes a point.
That's very important.
But in fact, I can raise another issue, and that is, I think, the one clinical situation where I think there is an in-stent stenosis, and we are going to put another stent, another drug-eluting stent, just in case. Then I think if something which is thinner, then it is lesser space occupying, and therefore that's a distinct advantage.
And one more advantage is that the OCT studies have shown very early healing. Within 30 days, more than 90% of the struts have already been covered. Neo-intima has already formed. So there is a case with these stents that we can reduce the duration of the DAPT. I think 1 month may be enough. This will be very useful.
Very important.
This will be very useful for patients who have high bleeding risk,
Yeah.
or anybody who has to undergo an emergency procedure or surgery where you need to reduce it.
Absolutely, you made a very, very important point, because the population which we are dealing with for occlusive coronary disease, the age group and their bleeding tendency, almost 20% of them could be considered in the high risk situation, high risk cases. So therefore, this is important, that anything that can help to reduce the DAPT duration is always welcome. And I think
some of this is across the platform, as you have been mentioning. And I guess these are all hypothesis generating, and we will have to slightly wait to make sure
More
that
data.
these can be translated into real life practice. But times are exciting, and the scope for using these technologies is going to, we have more and more evidence in the next few years.
Yes, I think it's very true that I think all this time we were concentrating on the drug and the polymer, and we never gave enough attention to the platform. And now that the design, the strut thickness, keeping in mind deliverability, keeping in mind inflammatory response, keeping in mind also the restenosis attached, I think all these factors are very important, and that will improve the both safety and efficacy, which we always desire and strive for better. And now that our population, the cases that we are doing, since the simple cases with a very small amount of myocardium at risk are being managed very effectively medically. So we are entrusted with the responsibility for more complex situations, more complex cases, and therefore these factors that we just discussed are going to be of very vital importance. What do you say, Upendra?
Yeah, I fully agree with you, because we're seeing more and more complex cases, we're seeing more and more high bleeding risk cases, elderly population, and we need a product which is very safe, equally efficacious, so that interventional cardiology, coronary intervention go on increasing. And I think the time has come that we need to do a freedom study again with this new generation stents, with
For
modern
diabetic
treatment
patients?
of diabetics.
Okay, fine.
And then see is that old concept that multi-vessel disease and diabetes should go for surgery. I think we need to relook at that with this kind of stents.
I think that's a good suggestion. Yes. And I think that the last question to both of you, would it impact the pattern of your practice? Would you straight away consider that utilization of ultra-thin stents, ultra-thin strut stents in your practice liberally, or would you be choosy? How would you be altering your pattern of practice?
I think it makes sense to use as much as possible ultra-thin, because it has been shown the market leader, the everolimus-eluting durable polymer stent, the new generation ultra-thin stents have shown to be equivalent and lower myocardial infarctions. And lower myocardial infarction is a very important thing, and a series of studies from Orsiro have shown that, and that's basically because of the lower strut, everything else remaining the same.
But then the recent study in Lancet, it was compared with Xience, and it was a non-inferiority trial, and then Supraflex, I think, and that stent, how does it differ from Orsiro? I think one thing is that, yeah.
The difference is that Supraflex or Supraflex screws, all the sizes, all the diameters are 60 microns.
Wow.
Whereas with the other stents, for up to 3 millimeters is 60, but it jumps to 80. At 80, it does not qualify to be defined in the definition of ultra-thin. So that is the difference.
Yeah. I think that I think not many people know
realize
about it. I think they don't realize, and therefore this is important.
Same is true for synergy. That also, as the diameter increases, the strut thickness increases.
As Professor Kaul was saying, when you look at the meta-analysis, you have signs. It's just not MIs, but also TLR, also stent thrombosis. Everything is moving towards being significantly better, if not better, statistically. And I guess the advantage will be even more in the more complex patients that you're referring to, that we get nowadays. So maybe the next study should be patients with more complex anatomy, so patients who have multi-vessel disease, patients who have a greater proportion of diabetics, to see whether the difference of the ultra-thin stent struts compared to the conventional thin struts, where the difference is teased out even more because of the higher event rate in the control arm. So that would be interesting to see whether that comes out in the near future.
In fact, we have planned a study, which I'm sure will approach you also. It's an Indian study comparing Supraflex with Xience in a diabetic patient population with multi-vessel disease. out of which 3/4 will be triple vessel disease and 1/4 double vessel disease, no single vessel disease, and diabetes treated as per the today's drugs, SGLT2, GLP-1, and liberal use of OCT, and also, fractional flow reserve to have complete revascularization. And the secondary endpoint of this study is to compare our results with the case percentages of freedom.
I appreciate. I think it's a very good idea because India is the capital of diabetes, and the diabetic problem is rampant, and we have to deal with this problem day in and day out. So it is relevant to our country much more, probably more than whatever it is in Europe, and therefore I think that's a good thought. I think we should be doing a more justice to diabetic population. I think combination of diabetes and coronary disease is rampant in our country.
Well, it's increasing in the West as well, but as you're alluding is when you do these studies, it's very important you do it more in a syntax 2 fashion, which is pressure wire guided, so it's physiological, and then anatomical optimization with some stuff imaging, so that we can push the boundaries of quality PCI to say it is equivalent to surgical outcomes, especially in the higher or at least the intermediate tertile of syntax score. So as long as it's done properly, it will be exciting times.
So my friends, we conclude that the ultra-thin strut stent concept is here to stay and needs to be explored, and the preliminary data shows that it has a great future, and working on various kinds of substrates of patients with the various combinations, permutations of clinical conditions can result into an improvement in both safety and efficacy. Thank you. Thank you both.
Thank you.